And to do that, I would need to go here and here and there. Good. I'm assuming that you can see that. Thank you very much for that introduction, Manuel. A large audience, and also an audience of people that I only know the names of from Twitter. So I know that this is an esteemed audience, and it's wonderful to be able to present to you some of the work that I've been doing with master student Jonathan Jays at Stellenbosch University. Jonathan is at the moment on an exchange in a very cold Sweden. This is work on the Spanish flu. And the reason, of course, that we are interested in the Spanish flu is that we are working during a time of a global pandemic. And knowing that also, it's important for me to start by saying that that many of us have lost friends and family, and so it's within that spirit also that I realized that some of this material can be quite tough to listen to, because we are very close to these kinds of issues. And so I do want to just stress that this is not an easy subject to talk about. I also realized that there are experts of the Spanish flu on the call, and so I'm very happy to take some history lessons also from them. But what I hope to show you today is a combination of history, of economic history, and then of policy making as well. So how do we think about health inequalities during a time of the Spanish flu in 1918, and perhaps what might be the relevance of those lessons for today? So this story starts with a train departing Cape Town on the 28th of September in 1918. And this train carried soldiers returning from the First World War, the trenches of the First World War. And these soldiers were returning home. You can imagine the euphoria and the excitement to see their family and friends again. And so they, whenever the train would stop at a station, they would disembark and go visit their family members that they haven't seen for a long time. One of the stops that they stopped at was a stop at Queenstown train station, and there a couple of soldiers got off, and they again kind of met with their friends, who presumably was one of these individuals was a man called Bunu, a young man, 18 years old, who was a farmer in the district. And soon after the train had arrived, some of Will's family members fell ill. And within 2 weeks, actually, 2 of them had died. Another couple of days later, another 3 family members had died. And by the end of the month, actually exactly a month later, the 28th of October, Will's Bunu himself had died. His uncle had reported his death in Queenstown. And so that's a very, very short anecdote of a massive pandemic that spread across South Africa, the Spanish flu or the influenza, in October 1918. And what we want to understand is, firstly, who were most affected by the flu, by the influenza. Perhaps ask questions about why certain groups or certain people were affected and not others. And then secondly, we want to understand to what extent did an existing health infrastructure exacerbate or actually reduce the inequalities that were already existing in that society. So that is really the kind of purpose of this paper, is to look at, is there a way to understand how health infrastructure and the inequalities within the health system and the healthcare services that are available, how is that perpetuated or perhaps even amplified by a pandemic? And of course, the motivation behind that is to perhaps help to understand how, especially when we started this research at the beginning of last year, how we might learn from that for the COVID-19 pandemic today. So to use the economist's rule of thumb, I'll provide you with some of these results. We're going to show you so that mortality rates differed immensely by gender and by age and by race. We'll try and understand why that is. We'll give you some explanations for that, but then we're going to use what we consider to be a very novel indicator, the ability to access healthcare services, to say something about how certain inequalities were amplified, but actually other inequalities were not, and actually they reversed. And that's what we believe is the major contribution to the literature of this paper. So the stylized effects of the pandemic. You'll see also I move quickly, so you're more than welcome to interrupt me if there's anything that is unclear. We have no precise estimate of the number of people that have died during the Spanish flu. The formal reports is about 140,000. Howard Phillips estimates that, using backdating later censuses, that it might be up to 500,000 individuals, and so finds a midway somewhere in between, suggesting that it might be between 250,000 and 350,000 South Africans that had died, which was approximately 6% of the population. But it is important to stress that this is a tentative number. It is very difficult to come up with precise and exact numbers. And we'll get to why that is. I'm not going to say too much about the virus, I think, except for the fact to say that it had a very different distribution as to who were affected than COVID-19. So COVID-19 clearly is most likely to affect older individuals. The Spanish influenza had actually a W distribution, so very young and very old, but then especially those in kind of 20 to 30-year-old individuals. And so 20 to 40, so around the 30s seems to have been most affected, and we'll show you some evidence of that. What is the kind of very brief kind of historical chronology? So there was a first wave that spread from Natal, then of course Natal into the Transvaal, on the mines, and in fact this, Reuters correspondent, this is a quote directly from Howard Phillips's PhD. It's a prophetic quote, I guess, or is to say, in view of the fact that such a very large number of people have been affected, again, this is the same date that this train leaves, the fact that there has been only one death must be considered to be reassuring. So this idea that, we've seen a lot of people be affected, but we don't see a lot of deaths, so we don't really have anything to worry about. That is, of course, the first less virulent version of the disease. A more virulent version arrived in Cape Town with these returning soldiers, and that, as I said, spread along the railways, and we see rapid increases in mortality rates across the Cape Colony in the month of October. So that is really the month that we're going to look at, that we're going to study, October, November, and December. I say that it covered the entire Cape Colony. This is the entire South Africa, of course, but what you clearly can see, just by looking at, these are the formal mortality rates by magisterial district, what you'll see is that there is some variation across the Cape Colony. So there may be two kind of observations here. The first is that those areas in what we call the Transkei or the Eastern Cape, densely inhabited by Black South Africans, were heavily affected by the Spanish flu. And then this kind of line running up, from Cape Town all the way to the mines along the railway. I mean, that's quite clear to see from that as well. But there's still some variation. Some districts we see kind of low levels of mortality, and other districts we see, again, high levels of mortality. And trying to explain that has been quite difficult. What might be the reason for that? So there are many different potential reasons. Of course, many of us have obviously discussed this over the last year or so, what might contribute to higher infection rates or mortality rates. There's obviously the properties of the disease. There are things about the natural environment. Initially, exposure to the sun and vitamin D was thought to be very important. There are population characteristics. So what immunization is there already? What is the age profile, household size perhaps? income levels, and then of course access to healthcare, density of living, social networks. We can think of the health infrastructure in the colony, so things like transport networks, access to clinics and healthcare, and then also personal behavior and government actions. So this is, of course, the main thing that has happened today is government lockdown. But even some of these kind of things go back to 1918. So they were not on the same scale as lockdown, but there were certain quarantines and restrictions. News and information spreads in various ways. This is a great study by Burstein et al., who shows how kind of different talk shows in the US and listeners to these different talk shows, how they reacted differently to news about the disease. We know that people have different beliefs about medical care and vaccination. And so that might also affect their response to the disease. So there's a host of different things. And what we try to do is trying to understand, in the first step of this paper, just what might be those correlates. So again, this is correlates. This actually graph comes from a paper that I'm writing with Dan Decat and several other scholars on, again, trying to understand these kind of correlates of the Spanish flu across these magisterial districts. And what it basically shows you is that there is very little correlation between the things that we might be able to measure and think might be important. So, for example, the non-white population share, so the share of Black inhabitants per Black and colored inhabitants per district. You don't see any correlations for most of the different regions. You do see some positive correlation in the Cape. Right, but this graph doesn't really tell you that there is a very strong correlation, except perhaps in the Cape Colony, but not elsewhere. If you look at density, population density, there seems to be absolutely nothing. There's no correlation at all here. And if you look at rainfall, which we were very proud. It took us quite a long time to draw this graph. Where we look at kind of rainfall, the deviation from the September-October rainfall in 1918 to 1919, and you would expect actually kind of a positive correlation, and there's nothing there. So, so we don't seem to find at the district level any obvious explanations for why you find these different mortality rates in 1918. So that's a puzzle. That's a conundrum which we hope to solve. How do we do that? We're economic historians, and so we go to the individual level history evidence and source material, and we've uncovered these death notices. And so this is the death notice of Wills Bunu, the individual that I've mentioned earlier when I started with my anecdote. We collected 40,000 of these death notices and transcribed them. So you can imagine that that's quite an exercise to do, quite an expensive exercise as well. But because we want individual level data, this is really the only way to do that. So these types of sources allow you to really kind of get at different kinds of reasons that might potentially help to understand correlates, again, of the disease. So who are the individuals most likely to be affected? And so we really kind of transcribe all of this and use almost all of these variables in one way or another. And so what are these variables? Of course, gender is important. We use address here. So Tsimasile is where Wills lived. He was 18 years old. His race was classified as Pingo or Sikosa. From the Cape Province, he was single, he was a farmer. And then you'll see here is cause of death, the Spanish influenza. And importantly, also actually the duration of his illness, which we we record as 1 month. And then I'll talk a little bit later about this important variable here as well, the medical man's name. So, having transcribed that, it's one slide, but it's months of work. We've got about 40,000 death notices from 15 towns that we choose, and this is chosen predominantly on a geographic basis. So we wanted coverage from the entire Cape Colony at this stage. So you have districts closer to Cape Town, districts in the Eastern Cape and Northern Cape. And you can also see the kind of variation in these districts, right? So here's Paarl, for example, and the percent of black residents in Paarl is only 2%, but the percent of colored residents in Paarl is 82%, right? So quite large variation. Compare that, for example, to Queenstown or Petty, where Queenstown is where Wills Bunu lived. You'll see 80% of the population is black individuals compared to 9% colored and 11% white. So again, these geographic variation allow us to also reveal other kinds of variation. We have gender, and then we'll talk a bit later about the doctor. There are major limitations with this kinds of data. And I think the most important one is one that also Howard Phillips recognized in his PhD study, is that a lot of, during the pandemic period, during this October, November, when the most deaths occurred, of course, not all deaths were registered, right? So that creates a serious issue. Not all deaths were registered simply because too many people died. To register a death, a family member typically would go to a commissioner, appointed by the government, and record and complete that death notice. And that just didn't happen in all cases, either because family members were unwilling to travel to town or unable to travel to town, or they were simply ill themselves. And so there are various reasons why we would think that would be problematic in the kinds of analysis that we do. We also want to acknowledge that this is perhaps not unique to the Spanish flu period, in that earlier times also probably had high levels of misrecording or underrecording. And so that's something that we also want to take into account. Other kinds of issues with the data is that they might be misdiagnosis. And this is especially something that I felt initially when I was reading these documents, is that it felt to me that a lot of these cases are actually Spanish flu, but they're not recorded as Spanish flu. And so how do we deal with that? And we'll show you, one way we try and deal with that. So this is actually how we do that. So we have this very basic text analysis where we classify the different words used for the reasons for illness or the reasons for death together. So we combine the words that look similar, that appear similar, and appear together, and then we classify them as the Spanish flu. So you'll see this group of words here. So clearly Spanish flu, or the Afrikaans Spaanse griep. But then all these other words are also related with the Spanish flu. So we are going to classify all of these words as the Spanish flu. And when you do that, as this graph shows you, so let me perhaps firstly say what this graph is. This graph shows you the reasons that people died between 1915 and 1920. I didn't mention it, but we not only transcribed death records for 1918, we did it from 1915 to 1920, so that we can compare the Spanish flu period with what came before and what came after. And so what we do here is we exclude all the Spanish flu deaths. So all the death notices that include the word Spanish flu, we exclude that. And then we look at the reasons for death over time. And what you can see here is that pneumonia is clearly beyond its normal seasonal peak, which suggests to us that a lot of people that died of pneumonia actually died of the Spanish influenza, but it was classified as pneumonia, especially early on, when news of the disease had not yet spread widely. You'll also see that in some, there's some cases where other kinds of illnesses are actually now underrecorded. So either people that would have died of these diseases now died of the influenza, or just, these deaths were simply classified as influenza because there wasn't enough time to do a proper investigation. So these are the 15 towns that we look at. You'll see again, our geographic spread. You'll also see we've got the racial classifications here, and you'll see, as one would expect, the large number of predominantly black individuals, or predominantly black districts that are here and in the Northern Cape, and then predominantly colored districts here in the Western Cape and closer to Cape Town. I guess these graphs would be quite familiar. So this is really taking all those 40,000 death notices and then mapping them out by district for in these kind of number of deaths per day. These graphs that we've become very, very used to, and again by race as well. And I guess the observation here is that there is some variation, not only in the incidence, so the mortality rates, but also in the way that it's affecting different towns at different time periods. So you'll see, Queenstown, again, the story of Will's Bunu, after meeting his friends that had arrived back from the war. Clearly, there's this massive effect very quickly in Queenstown, whereas a town like Oudtshoorn seems to have a much longer time of where the disease is kind of prevalent in the town. We can obviously compare our estimates to earlier estimates, to the kind of formal estimates that was published by the Influenza Commission. And here we also kind of find interesting results. In some places, we find that the formal estimates, as Howard Phillips reported in his, again, PhD, are much larger than the ones that we find. And so that's clear evidence of that that there are missing deaths, that we are not capturing all the death notices because some people simply did not fill in. We're not capturing all the deaths because some people just simply did not fill in all the death notices. But in other places, you'll actually see we're above what was reported before, and that's because we are properly diagnosing these deaths rather than just attributing it to, say, pneumonia. So they are, again, countervailing factors. This, we believe, we can incorporate in our final analysis, and I'll briefly allude to that a bit later on. What do we learn from this so far? So the mortality rates, as I said, were different than COVID-19 today. We find a W-shaped graph. And so what you'll see here, these are for Black and colored individuals for just 3 towns, for Elliot, Oudtshoorn, and Queenstown. And what you'll see here is, clear evidence of a W-shape that's happening here. So high mortality rates for the old, for the very young, and then for those between 20 and 35. Right? You'll see that also here. So this is both for men and for women. You'll see the same in Queenstown, perhaps less of an effect for Oudtshoorn. And actually, when you look at white individuals, firstly, I mean, you'll see, I should have stressed this, you'll see large differences in mortality rates for Black individuals than for white individuals. But you'll also see that, white individuals are mostly concentrated in these kind of middle ages, so not middle ages, but between 20 and 40 years old. You'll also see that there are different gender effects here. So for white individuals, you'll see mostly that it was men that were affected. And for Black and colored individuals, you'll actually see it seems to be 50-50, but in fact, it might be actually that, females were perhaps more affected, certainly in the Queenstown area. So to do these kinds of analysis, we need obviously a denominator. And so there we use the 1911 census. We have a 1918 census, but unfortunately only for white individuals. So we can do a really fine analysis for 1918. And then you clearly get the same kind of results. So the size of the bubbles now are the deaths. And what you now see is, there were several kind of deaths. So these are mortality rates, how far you are on the X scale, but the size is the number of deaths. So you'll see actually high levels of mortality, but actually there were very few old individuals. So very few actually number of these older individuals that died, but you see very, very high numbers of, again, people in their prime, right, between 20 and 35 years old. These are white males and these are white females. And then, of course, high numbers of children as well, so babies, which is, again, very, very different from today. Here we just do a scaling. So it might be that those outliers are just because we have very few individuals in the sample. And so we want to just kind of correct for those dramatic outliers. And if you do that and you add a confidence band, you find the following result. And that is that only for white individuals, we find it's the men that seemingly had a much higher mortality rate. Women also had higher deaths, but their mortality rates actually or high numbers of absolute deaths, but the mortality rates weren't that high. It was really mostly white men that were most heavily affected. But I think here is a slide that really, to me, was surprising and also something that I should have thought about before. So what you can, if I go back, you'll see that there are, we've talked about this, high numbers of infant mortality in the Spanish flu period. And so a lot of people have attributed the, say the Spanish flu, one of the things that it did was to have high levels of infant or create high levels of infant mortality. But if you actually compare, so what we do here is we compare the mortality period to what the mortality rates were before the Spanish influenza. So we compare the Spanish influenza mortality rates to what the mortality rates were before and actually after the influenza. And then what you see is, in fact, very, very low levels of difference. So not a large difference between the infant mortality you find during the Spanish flu and infant mortality that you find before and after, suggesting to us that infant mortality was simply very high during this period. So one should be cautious to attribute all the infant mortality to the effects of the Spanish flu. What is clear from this is that the outlier mortality rates were, again, these people between 20 and 40, but in some cases, actually, you see even like 10-year-olds so teenagers really having very high levels of mortality relative to what came before. And so I think that is quite surprising. That is not something that we had known before. Okay, so those are the kind of mortality conclusions. So it clearly seems to be, there are age effects, there are gender effects, it seems, and there are race effects. And so what we want to do now is try and understand why that is. And we're going to look at one specific reason. We cannot look at all the reasons because we unfortunately simply don't have individual level data on all the kind of potential explanations for why that might be. But we have one variable that we're going to look at, and that is going to be access to healthcare. And today and in the past, access to healthcare has not been equally distributed, and that is there's a simple explanation for that. If health is a normal good, the rich will tend to consume more of it, and so that's why typically the state intervenes, is to ensure that everyone at least have access to a certain level of healthcare. But despite these interventions, inequalities tend to persist. And there are a host of different inequalities, types of health inequalities that one can imagine. And again, over the last year or so, these health inequalities, certainly in the context of COVID-19, has been discussed at length. So one can think of race, ethnicity, gender, immigrant status, sibling rank, locations, or urban or rural, cultural traits, beliefs, all of these kinds of things. Of course, those are all demand side things. And you can also think of supply side things. So what type of health infrastructure is available? What are the fees? What are the competency levels of the medical staff? Is there prejudice? Is there stigma? Perhaps there's just like very poor recording. So what we are kind of finding is very different from the actual experience. So all of these are, very, very plausible explanations for why you find these inequalities that persist over time. It's not only that these inequalities persist, but the literature suggests that during a pandemic, these inequalities actually are exacerbated. So they become amplified, they become bigger, they become larger. And I'm very sure that most of you are aware of the especially large literature in the US, which especially stress the effects of the pandemic on minorities, especially African-American neighborhoods and communities. And so partly of our purpose here was to see whether we see similar kinds of the amplification of inequalities or the exacerbation of inequalities in the influenza period in 1918 in South Africa. And to do that, we are going to study we're using a novel indicator. So we again use those death notices. Here's again Will's Bunu's death notice. And then we look at this variable here, the medical man's name. So you'll see that it's blank in the case of Will's Bunu, and that is because Will's Bunu did not have the ability to access medical care. He did not have a doctor present at his death. So we make a couple of assumptions also when we do this. We are assuming that someone who has a doctor's name had access to medical care. Now that might be untrue in the sense that that person might simply have died in a hospital where a doctor came after the death and checked on the patient and recorded the reason for death. We would make the case that that's still at least a proxy for some access to medical care, even if that patient wasn't treated by the doctor. Of course, some other patient might have seen a doctor for months or for weeks at least. And so the treatment, the quality of treatment might be very different, but it's a proxy. It's one attempt that we have that we use to get at whether these patients, these deceased individuals, whether they had access to medical care or not. And so here we report again for those 15 towns, again for 40,000 death certificates. We are going to report the numbers. So here's the pre and post pandemic numbers, and here are the pandemic numbers. And so what you can see clearly is that here is the percentage of doctor present for those different districts before the pandemic and during the pandemic. And so let's just look at Cradock. You'll see 66%, or 2/3 of all patients had access to a doctor before the pandemic, and now it's a quarter during the pandemic. So clearly a decline. In Elliot, 30% to 7%. You'll see in some cases, in Kuruman, it's the opposite, right? So from 16 to 36%. So there's also some variation in there, but predominantly all the declines are from the high level. So here's Paul again, 86% had access to a doctor to 37%, 23 to 4. You get the kind of the story here. Clearly a decline in access to healthcare. So to go back to our original limitation of this data, we said that during the pandemic, we would expect that there are fewer death certificates that are recorded. So what we show, what we argue with these numbers, that even conditional on the fact that some people did not even have a death record, death notice, we still see major declines in those that have access to doctors on those that could record death notices. So, right, so we only look at those that could record death notices. And even then, we still see these major declines. If I have to summarize the paper in one slide, it would be this one. So two things I think that stand out. Firstly, what we report here is the percentage of death certificates with a doctor present, so with access to healthcare over time, so over the 5 years that we look at it. What you can clearly see for females and for males, what you can clearly see, at the top, you have white individuals, then you have colored individuals, and then you have black individuals. And you can clearly see large differences already before the pandemic in access to healthcare. But what you can clearly see also, and that's the second and major and important finding, is that these differences are amplified during the pandemic. So for white individuals, there's almost no difference between access to medical care before the pandemic and during the pandemic. For colored individuals, you see a clear decline. I'm talking about females now, but the trend for males are exactly the same. And then you'll see for black individuals also a dramatic decline. So that during the pandemic, you'll see vast differences between different race groups in access to medical care. So this, when we first drew this graph, it was really striking because we had expected, of course, that was our hypothesis, but we didn't expect it to be this large and this obvious. There's another way to represent it, and that is here. Let me just perhaps say already you can see, so the top row here is for black individuals, colored individuals, and white, and you can see the vast differences again during the pandemic for black individuals, say, compared to white individuals. But there's something else that you want to see, and let's just look at white individuals here. You'll see that before the pandemic, 20 to 24-year-olds have the most access to doctors. During the pandemic, actually that declines. So there's already some evidence that in this type of inequality, an age inequality, seems to reverse. And I'll get back to that when I get to the next slide. Let me just check the time. Okay, I've got about 5 minutes. So what we do is we say, can we explain these access, these kind of varying levels of access to medical care, and add all of these explanatory variables that might help us understand it. And so the first one, and I'm not going to go through all of these coefficients because there are too many, but let me explain the first one because you've already seen that in the graphs. So this baseline coefficient here, so it's negative, that's 0, tells us that black individuals, the red one, so tells us that black individuals have less access during the baseline period, so during normal times, than white individuals. What this blue coefficient tells us is that over and above that negative, that disadvantage, there's an even bigger disadvantage during pandemic times, right? So this negative coefficient is an interaction term. So one should see that as over and above the negative effect of the pandemic, of normal, the baseline period, you still have additional. So this is a clear evidence of an amplification or an exacerbation of inequalities. There's a negative coefficient, and on top of that, there's an even bigger negative, or there's another negative coefficient. So that becomes even worse, right? The same is, of course, true for colored individuals. So the reference category here is white individuals. Interestingly enough, we don't find any evidence for gender. So that was quite surprising to us. So there's no inequality before the pandemic, and there's also no inequality in terms of gender during the pandemic. So that is quite surprising. But then there are some inequalities which are reversed. So here, for example, individuals that are older than 70 have less access to doctors before the pandemic, but more access to doctors during the pandemic. So relative to their previous disadvantage, now they kind of return to what the average is if these coefficients are the same size. So there's some clear change in the type of inequality. Was inequality before, and now that reverses. We can do the same for types of occupations, and actually there we also see some reversals happening. Let me just, so here we have a signature, so whether someone signed their death certificate, and we use that as a proxy for literacy, or perhaps broadly defined for class. And there you see during normal times, individuals with high literacy have better access to medical care. It's what we would expect, conditional, of course, on all these other factors. There's no difference, it seems, during the pandemic. So having more literacy doesn't help you have access. Here we have immigrants from Europe seems to always have better access, even during the pandemic. If you're born outside of the Cape Colony, but in South Africa. And perhaps this one was, I think, again, a very interesting one. So maybe worth highlighting this one. So during normal times, having someone of your family die in the previous week has no influence on whether you have access to healthcare. That's the red dot there. But during the pandemic, actually, if someone of your own family had died during the previous week, and again, we use a proxy there for surname, then you clearly have a negative coefficient, which means that you have less access. There's a lower probability of having access to a doctor during a pandemic if one of your family members, and that kind of suggests that the disease kind of spread within the family, and family resources were really stretched in those families that where the disease was prevalent. The final thing I'll mention here is urban-rural. So we had to try and find a way of creating a proxy for urban-rural, and you'll see here during the baseline period, those living in, so we did that by just creating a dummy for street and road and stad. So when those words were used in your address, we assume that that's an urban address. And when you do that, you'll see that during normal times, people in urban areas, so in cities and towns, have better access to doctors. But actually during pandemic period, you'll see that they have far worse access to doctors. And so that, I think, is again something that's worth highlighting. I think I'm running out of time, but because there's one thing I do want to say, so I'm going to skip this. This is just where we interacted with various different kinds of race dummies. One potential explanation, right, is that it's not a demand side thing. It might be a demand side thing in some sense. So, people in poorer individuals or people in certain circumstances have poorer access to healthcare, but it might also be a supply side factor. So in the sense that, as we spoke about before, it might be that doctors have certain prejudices and biases. So they might not want to see, again, these are all white doctors, healthcare system. It might be that these white doctors are less keen to see Black patients during times of a pandemic. So that's something that we try to investigate, because we have the names of the doctors and because we have the duration of the illness. So how can we use duration to determine prejudice? But economic historians have become very creative in using numbers. And so what we do is to say the following: if you're a doctor and you do not know or do not care actually about a patient's well-being, you are just going to fill in a form and you're going to write a rounded number. You're going to say, how long was this patient ill? This patient was ill for 1 week or 2 weeks or 3 weeks. If you really care about the patient, you'll ask the patient, how long were you ill for? And the patient will say, I was ill for 12 days or 15 days. So that's a more precise number. And so we're going to compare the precision of the different reports on these death notices to see whether we kind of get at differences in the way that doctors reported Black, colored, and white death notices. And I guess the happy news is to say that we find no evidence of obvious prejudice. So what these kind of graphs just show you is before and after the pandemic for the different race groups. When there's a doctor present, actually the lines look very similar. So there doesn't seem to be some kind of heaping for Black patients as we would have expected, but not for white patients, for example. During the pandemic, we actually do see heaping, but it's the opposite. It's the opposite of what we would have expected. So it's heaping for white patients. You'll see that clearly, they're around certain numbers of days you see, and far kind of flatter for Black and colored patients. So that's difficult for us to explain. We're not entirely sure why that is, but it's the opposite the opposite result of what we had hoped to find. Of course, when there's no doctor present and there's just an official filling in the form, typically there's a lot of heaping, and this is exactly what you see in both of these cases. So I think I'll have to stop there. Our results suggest that healthcare inequalities were not exacerbated across all dimensions. It was clearly exacerbated along racial lines. So we see that Black South Africans had, before the pandemic, already poor access to healthcare. During the pandemic, those inequalities were amplified, and so access just became much worse. Why exactly that is, we need further investigation. We've tried to understand that with these potential prejudices, but we don't see that. Doesn't seem to answer that question. And in fact, Howard Phillips reports on this in his PhD. He asks, right? So one of the questions was how did people respond to the pandemic? Do we see greater racial prejudice during this time? And in fact, there's some evidence of, here's Dr. Abdurrahman, who was kind of quite a leader in the colored community, expressed the thanks of the colored community to those citizens who had so ungrudgingly and unselfishly helped them during the pandemic. So there's some evidence that actually this wasn't a time of really kind of racial animosity, but actually a time when people tended to support one another. That doesn't really answer our question then of why we see these inequalities, racial inequalities, exacerbating, and that hopefully we'll be able to do in future research. Thank you very much.
Okay, thanks, Johan. There are some questions here. For For instance, there is a question from Sharon. It may be that if breadwinners and carers died, then the children in the household were more at risk of death. We know that mother's death puts her children at higher risk of death. That may explain the excess death in around 10-year-olds during that period. I don't know if you would like to comment on that, or you would like to collect more questions, because there is.
No, that's an excellent question. So one of the things it's actually a question that was also mentioned by someone at a earlier presentation, and one of the things we can do to help exploit it, to understand that, is to look at who reports the death. So if it's an uncle, or if it's a mother or a father, it's typically a father and an uncle, a male relative. But that might help us to understand, say, the family networks, for example. And if it's a father, that suggests at least that the father is still alive. So if it's not a father, one would have to question whether the family structure is just really fallen apart. And that, if we throw that into a regression, it might help us understand why certain families were just, completely, affected by the disease, and others perhaps not so much. So I think there are ways to investigate that. We haven't done it yet.
And a follow-up from Sharon, just to be clear, when you are talking about access to a doctor, you really mean have a doctor making the cause of death diagnosis on the death notice?
Yeah, so again, as I said before, it's a proxy, it's the best we can do. But because we have, roughly a large proportion of people not actually having any access to a doctor, so no doctor filling in the death certificate, that already gives us enough variation to work with, to say even just minimal care, having access to a doctor would be, I guess, already a sign that someone in perhaps better times would have been able to access healthcare facilities, compared to large proportion of the population who simply didn't even have that option. But exactly what these, what the care was, one thing I perhaps should add is that this is a pandemic period, and no one knows exactly how to treat the pandemic. So actually having healthcare, having access to healthcare, so you might wonder about selection here, right? So those that have access to healthcare might obviously be less likely to die, so they might not appear in the death notices. I guess the good thing about the Spanish influenza is that no doctor knew how to treat this. Everyone was experimenting. So actually, we can make the assumption that having access to healthcare doesn't actually help your likelihood of surviving. It's really just a proxy that we can use to ascertain the levels of kind of healthcare infrastructure in the colony.
Thanks. There is a question from Jesse. If the goal is to say something about the effects of seeing a doctor on mortality, how can we do this given that we don't see the people who didn't die?
Yeah, no, that's an excellent question, Jesse. I tried to get at that in the previous answer. I think also it's important to keep in mind that we are comparing those that die during the pandemic to those that die before the pandemic. So it's not that we're not trying to look at those that die versus those that do not die. That we cannot do, because you're right, we don't have any evidence on those that do not die. So we're really only trying to look at this kind of relative mortality, the reasons for why the pandemic is worse than other periods. So that's really the only answer I can give there.
From Tanya, could you determine the death rate of medical personnel by any chance?
Yeah, we do include a nurse. I mean, we have too few doctors that die in our sample. So again, these are 40,000, but of course, there are several thousands more, and we are in the process of transcribing more towns. We include a nurse and we include railway workers. Unfortunately, we only have 17 nurses, so that's too few to really say anything meaningful. What we find, though, is that railway workers are more likely to see a doctor. So our explanation there is that they would have been the ones that would have contracted the disease first, and still would have had time to, there would have been space available at doctors and healthcare facilities to access. But for in terms of medical personnel, we really don't have enough points of observation.
Thanks, Johan. There is a question from Lardo. It would be interesting to understand if doctors were in some sense called into hotspot areas so that they were away from their normal practice localities, as partly explaining the deterioration in access to doctors.
Lardo, that's a question I have not thought about at all, and it's an excellent question. So I need to think about that. As far as I've read, I do not know whether there were doctors that were called to certain areas. I can imagine that might be the case. I think that was the case in cities. I'm not sure that it was the case between towns and cities. So I don't know yet. But that's a really good. The one way we can do that though is to look at the names of the doctors. So we have started cleaning that variable. You would have seen that in the final slide. And so we can look at, the doctor, we can only, for example, look at a sample where the doctor was present before and during the pandemic, so that you at least control for doctor movement. But it's a good question, and it's something that I haven't thought about before.
Well, thanks, Johan. There is a comment here, anonymous. I find it difficult to believe that there was no discrimination or no effect across gender. I'm worried that your analysis relies too heavily on the limited data and not enough grounding on political economic analysis. That being said, I wonder what economic lessons you've learned that you have drawn about the current COVID crisis.
I was equally surprised by the gender finding, simply because I think it's now standard knowledge that people would have thought that men were most likely affected during the pandemic. I think Howard Phillips also mentions the reasons for that is that men were seen as having to go to work, and so they were more out and about, and therefore more likely to contract the virus. This evidence suggests that once, for example, we include colored and black individuals, that result changes. What I would want to do in future is to interact that with race. So it might be that we see white men and black and colored women being more likely to be affected. So then there's this kind of intersectionality that I think is interesting to understand. What are the lessons for today? I think one needs to be cautious to draw any direct lessons. I think when we started this, the hope was that we'll come up with the solution and be able to inform government of what to do, and then everything will be well. I think the one thing we've learned is that it's messy and the data is messy, and therefore one should be very cautious in making kind of bold claims. But I do think what we add is an understanding firstly about perhaps the kind of urban-rural effects. So I think clearly there's something about the pandemic that seems to affect. Well, it's not a big surprise, I guess, but urban areas quite a lot, and also the kind of effect of transport networks. So we see in some of the analysis that we've done, very preliminary, where we do GIS analysis, so we plot these addresses on a map. I mean, there's some evidence that it's around transport nodes and schools and hospitals, but I wouldn't want to claim too much about that. I think in the end, to me, it's about how social science, how valuable social science is just understanding these the diverse experiences of people. And so here we have a literature which emphatically says all inequalities are exacerbated and amplified. And what we show here is that that's not true. There are some that are more amplified, or in some actually that are not amplified at all and reversed. And so we really kind of, with individual level data, can drill down and understand who exactly is most likely to be affected. We don't have the answers about why exactly that is. Why is it that we see that this racial dummy becomes more negative whereas other kinds of inequalities do not. You know, we don't have the answers to that, but I think that's really the purpose of science and research, is to try and get at those questions that are not as simple and easy to understand as, you know, one would want to believe.
Thanks, Johan. I would like just to add a comment on the last question, because I also found interesting your slide number 30. It seems to me, because it seems to me that there was a sort of fight for resources, right, during the pandemic, and therefore maybe it's something for you to think about a political economy channel, a sort of mechanism. Maybe for the next iteration of this paper, but there was a sort of fight or resources being transferred to the white population. So you can probably think about that. There is a question from Howard. What evidence is there that the presence of a doctor could do much to save the life of a flu patient? In the US, it has been argued that nursing was far more influential. On the chat box.
Yeah, no, I don't think there is much evidence to say that having access to a doctor helped prevent the flu and the effects of the flu, but that feeds perfectly into our, you know, use of this proxy, because we really are not there to say our question is not which factors helped reduce the mortality rates. Our question is, can we use this, existing health, to what extent were these existing health inequalities exacerbated? And if we use this proxy of access to medical care, in this case, the doctor signing the death certificate, that to us is a great way of getting at that question, especially if the doctors are pretty poor at treating patients, because that then means that we have everyone in our sample, both those that went to the doctor and those that didn't, and there's no real difference in whether they survived or not. So I think that's it's a good question. My suspicion is that doctors were actually not helpful, and in fact, I think one could even make the case that they themselves were perhaps vectors of the virus. But that really kind of speaks to our the way we use that variable. It doesn't run counter to it, it actually adds to it.
Thanks, Johan. And that is from Patricia. Have you taken into account the life expectancy in 1918 in explaining the low number of deaths among older populations?
Yeah, it's not that they are so they are in low absolute numbers, you're right. So that's simply because there are fewer old individuals. So that's true. I guess we typically work with mortality rates. So that would be obviously the denominator would be the number of people alive. And there you can see that the mortality rates are quite high. So it's not that I want to dismiss the fact that there were not a lot of people or a high percentage of people that were dying in their old age. It's just that there were few of them. So you're right that because of lower life expectancy, there were few of them, and so the absolute numbers are quite small. It really was, if you were just to kind of ask what is the likelihood when you see a dying person or a deceased individual of them being 20 to 40, it would be very high, because that's where most of the people were. That's the age category of most of the people that were dying.
Thanks, Johan. Just perhaps one last question from Theo. Did the health system not just collapse due to the pressure caused by the pandemic?
Yeah, I think you can. That's exactly right. Certainly in say in Cape Town or so, I mean, it was a major collapse, and then I think for precisely that reason, it's interesting to us to look at that graph again. I guess it's Manuel's slide 30, and show that even with the collapse of a healthcare system, white individuals still have access to a doctor. Versus colored and black individuals, and so I think that's exactly why we want to ask these kinds of questions, because that exposes the kind of extent of and Manuel, I must say, to respond to your question, that's something that I think I need to think about, is So how were resources used? It comes back to the earlier question about, were doctors kind of put in certain towns perhaps, or sent to certain towns, or removed from certain towns perhaps, but to allocate resources in a different way to benefit, the electorate, which was at that stage mostly white individuals. In the Cape, at least, there were still coloured individuals that could vote, but clearly these would have been issues that I think one really should consider in understanding why it is that the white line remains flat and the coloured and black line remains, falls precipitously.
Okay, thanks, Johan. Thanks. Before we go, Johan, thank you very much, and thank you all for. I'm sharing my screen, folks. So before we all disappear, just to let you know that the full program is already available on ERSA's website, and we see each other. Hopefully, we see each other again in 1 month's time, and where Elias Papaiwan from LBS will be talking about religion and educational mobility in Africa. I would like to thank you guys again for attending, and see you next month. We will be ending the meeting now. Thank you.